Let's move on to the distal RTAs. Again, recall that the kidney maintains acid-base homeostasis via three mechanisms. 1. Bicarbonate reabsorption at the proximal convoluted tubule. 2. Bicarbonate production or generation at the cortical collecting duct. And 3. Hydrogen ion secretion, buffering, and excretion in the urine, which enables the bicarbonate generation. The dysfunction in distal RTAs occurs at the cortical collecting duct, whereby bicarbonate generation cannot occur, resulting in a non-anion gap metabolic acidosis. This is also called a type 1 RTA. In general, recall the following mechanisms must be intact for hydrogen secretion and bicarbonate generation to proceed. 1. Adequate sodium delivery to the cortical collecting duct. 2. Normal aldosterone levels and activity at the mineralocorticoid receptor. 3. Low intracellular sodium concentration generated by the activity of the sodium-potassium ATPase on the basolateral membrane. 4. Sodium reabsorption by the ENaC within the apical membrane of the principal cell, which generates a negative interluminal gradient. 5. Alpha-1 intercalated cell hydrogen ATPase activity and hydrogen secretion. 6. Impermeability of hydrogen efflux back into the cell and into the extracellular space. 7. The generation of ammonia and H3 at the proximal convoluted tubule and ammonium trapping. Breakdown in any one of these processes may result in a non-anion gap metabolic acidosis, and more specifically, a distal renal tubular acidosis. Notably, it is the inability to excrete hydrogen ions that results in the inability to acidify the urine, resulting in a urinary pH greater than 5.5. Now let's discuss a little bit more in detail the mechanisms involved in the various types of distal RTAs. Recall that the first step of bicarbonate production is sodium reabsorption by the principal cell via the ENaC. The remaining negative charge within the tubular lumen promotes hydrogen secretion by the hydrogen ATPase. Then hydrogen is buffered by ammonia or titratable acids and cannot be reabsorbed due to an impermeable cortical collecting duct membrane. If the first step of sodium reabsorption is disrupted, a negative charge cannot be formed within the tubular lumen, and the hydrogen ATPase cannot secrete hydrogen ions. Similarly, there is no negative charge driving potassium ion movement into the lumen. This is known as a voltage-dependent RTA. The most common cause of this RTA is reduced delivery of sodium to the cortical collecting duct in the setting of low effective arterial blood volume. Recall, low effective arterial blood volume results in upregulated proximal sodium reabsorption, resulting in low sodium concentrations in the distal nephron. Remember that hyperkalemia sets this RTA apart from others. It is a common feature of the voltage-dependent RTA because potassium cannot be secreted when there is no negative charge in the tubular lumen. Other causes of voltage-dependent RTAs include drugs that block sodium reabsorption at the ENaC, such as triamterene and amiloride, obstructive uropathy, sickle cell anemia, and lupus. Patients classically present with low normal blood pressures, non-anion gap metabolic acidosis, hyperkalemia, and a urinary pH greater than 5.5. The two types of classic distal RTAs are 1. A defect in hydrogen secretion by the hydrogen ATPase pump, and 2. A leaky apical membrane. These patients classically present with low normal blood pressure, non-anion gap metabolic acidosis, hypokalemia, urinary pH greater than 5.5, and calcium phosphate nephrocalcinosis and nephrolithiasis, like kidney stones. The stones are on account of more alkaline urine with a buildup of calcium phosphate due to bone breakdown from chronic metabolic acidosis. A defect in hydrogen ion secretion can be congenital or acquired. Acquired causes include Sjogren's syndrome, sickle cell anemia, multiple myeloma, lupus, or drugs such as lithium or toluene. A leaky membrane is almost always caused by a potent antifungal called amphotericin B, which reduces tubular membrane integrity. Normally, the cortical collecting duct membrane is impermeable to hydrogen ions, but if the membrane is compromised, hydrogen can flow back into the cell. In contrast to voltage-dependent RTAs, a more negative charge in the tubular lumen due to lack of hydrogen secretion promotes potassium secretion via the ROMK found in the principal cell and hydrogen-potassium exchange found in the α-1 intercalated cell. Thus, classical type 1 RTAs are associated with hypokalemia. Both classical and voltage-dependent RTAs are considered type 1 RTAs. In all cases, hydrogen cannot be secreted, therefore bicarbonate cannot be formed. Now we'll talk about a distal RTA that results from a defect in hydrogen ion excretion and buffering. This can occur in the setting of hypoaldosteronism or aldosterone resistance, which is also called a type 4 distal RTA. To better understand this mechanism, we must first understand what happens under physiologic conditions. Normally, aldosterone is a hormone that is designed to defend hypotension by stimulating the reabsorption of sodium by the kidney. In doing so, it works at the principal cell to indirectly promote potassium secretion through the apical ROMK channel. The mechanisms by which this occurs is complex, but we will try to cover it here. Aldosterone activates the mineralocorticoid receptor and does the following things. 1. It activates the sodium ATPase located at the basolateral membrane, thereby driving a low intracellular sodium state, resulting in a strong gradient across the apical membrane. 2. It increases the number of ENaC in the apical membrane. Steps 1 and 2 facilitate sodium movement into the cell, creating a negatively charged lumen. 3. Positively charged potassium moves into the tubular lumen. And finally, the hydrogen ATPase located in the α-1 intercalated cell has increased activity, thereby upregulating hydrogen shuttled into a negatively charged tubular lumen. Without aldosterone to activate the mineralocorticoid, the aforementioned processes cannot occur, which results in the presentation of a type 4 distal RTA, which includes a low normal blood pressure, a non-anion gap metabolic acidosis, hyperkalemia, and a urinary pH greater than 5.5. Downregulated ammoniogenesis plays a larger role in a type 4 RTA. This is because in chronic hyperkalemia, ammoniogenesis in the proximal convoluted tubule is downregulated. We briefly touched on this mechanism in the acid-base handling by the cortical collecting duct module. When extracellular potassium is high, potassium moves into cells. To maintain electroneutrality, hydrogen shifts out of the cells, resulting in high intracellular pH. The cell detects an alkaline environment, thereby inhibiting glutaminase and resulting in reduced ammonia production, NH3. Reduced ammonia delivery to the cortical collecting duct reduces the buffering capacity of the kidney and ultimately results in reduced ammonia trapping, hydrogen secretion, and ammonia excretion. This again results in a non-anion gap metabolic acidosis, and as mentioned before, is typical in a type 4 RTA. Let's take a clinical example to drive this point home. We have a patient that presents with a diagnosis of Sjogren's syndrome, an autoimmune process that primarily affects the glands that produce tears and saliva, leading to dryness in the eyes and mouth. They have a low serum bicarbonates consistent with non-anion gap metabolic acidosis. What would you expect their blood pressure, serum potassium, and urinary pH to be? Bonus question: what defect is driving this process? Sjogren's syndrome creates a distal type 1 RTA by inhibiting the function or expression of the hydrogen ATPase located on the α-1 intercalated cells of the cortical collecting duct. As we have learned in this video, these patients classically present with low normal blood pressure, non-anion gap metabolic acidosis, hypokalemia, and a urinary pH greater than 5.5. Don't forget that these patients also have problems with calcium phosphate nephrocalcinosis and nephrolithiasis, which is another term for kidney stones. You may refer to this infographic, which lists the types of RTAs, both proximal and distal, as well as the clinical scenarios that sets them apart.